care medicine. This is another webinar which we are conducting from that conduct one good webinar for all those who are interested in different fields of critical care medicine. And this time we have selected a topic which is a futuristic topic, that is artificial intelligence. And as you know that our Narendra Modi has also declared that next 25 years India is going to grow like so that it should become a developed country and like that, and we should also start thinking on that line so that everyone of us should have this knowledge which of artificial intelligence is very, very important, because in future this is what we are going to get in our plate from all the slides, not only the clinical practice but also in our academics as well as research. And to do this discussion, and I'm very proud to say that we have one of the best moderator from our country as far as critical care is concerned, Dr. Subhash Todi. I think he doesn't need any introduction. He is the senior most intensivist from Kolkata. He is associated with Amri Hospital in Kolkata, and he'll moderate the session. And to discuss this entire issue of artificial intelligence, we have with us Dr. Banani Poddar. She is Professor and Head of Critical Care Medicine in SGPGI Lucknow. We have with us Dr. Rakesh Garg. He is a Professor of Anesthesiology and Critical Care Department at All India Institute of Medical Sciences. Dr. Harjeet Dumra is a Senior Pulmonologist from Ahmedabad. And Dr. Venkatraman Kola, he is one of the senior most intensivists from Yashoda Hospital, Hyderabad. So we have a very strong panel to discuss this issue, and I understand that all of you will definitely enjoy and you will get a very good feast at the end of the day, because this is one topic which I feel that at least the young generation of our intensivists, they must understand this, because this is the future and this is what the entire world is looking for. So without wasting much of time, I think I should hand over the mic to Dr. Subhash Todi to start the proceedings. Sir, please.
Thank you, Pradeep. Though Pradeep has mentioned it to be futuristic, but I think artificial intelligence, or to be correct, and augmented intelligence is very much in the present. You know, when we call an Uber or we call an Ola or we do an Amazon shopping, these are all AI. In fact, the healthcare industry is lagging behind, much behind the travel industry, the hospitality, the other industries in utilizing artificial intelligence. So for those industries, it is their livelihood now. It is the presence. So I think it's time now that the healthcare industry also wakes up to it. I think our administrative folks are gradually getting geared to it. So I think it's very important for clinicians to be aware of the nitty-gritties of AI. So let me start with Dr. Rakesh Garg. Dr. Garg, just if you can summarize, what exactly are these different terms which comes artificial intelligence, deep learning, machine learning, and all? Please.
I think this is, as you rightly said, and Dr. Pradeep Bhattacharya also mentioned, that with the concept of digitalization, we are getting more exposure to it. And in real time, we have experienced certain things that when we desire something or when we expect something and enter the system, it gives us some results. And we have been using it. Like say even Google uses it for many purposes. So what exactly means is that we are giving a power to a machine which has loads of millions of data into it to process those data and give us the desired results. And those desirability, what desired it is, even that can be captured by these machines using various types of algorithms. So this is broadly we can say is what is the artificial intelligence, which is mimicking the many of the gray cells of the brain into multiple aspects and give you some output that is concerned to us. This is as simple as that when we think that when we have emotions, somebody asks a question, our frontal cortex will be activated, our limbic system will be activated, our emotions will be activated. So our brain is working into multiple integrated gray cells connectivity. Same is been done by these machines now, and which is being labeled as artificial intelligence. And if we just go a little forward, artificial intelligence is a very broad umbrella term. It is now further subset into, say, a machine learning or a deep learning, and it is coming into various learning resource management terminology, which has been used this. When we say machine learning is basically one component where it has various developed algorithms. Those will take various inputs from various data and multiple resources. But this is simple when we talk about the algorithms which we design for, say, a clinical management. They will be having data capturing for multiple areas and try to give us basically an insight into what we have asked these machines for. So this is what is called deep learning. This is something called machine learning. And these whole resources basically comes into when we say learning resource management based on artificial intelligence. So this is a very broader term, and I'm sure this has found a very important role in medical science now, and that's why these buzzwords are coming into the medical science.
Thank you, Dr. Rakesh. So I think we can put it as data science. If we put it under one stream, probably data science is probably one which captures everything, and within this data science stream, artificial intelligence could be one aspect, an umbrella term, as you mentioned. And within artificial intelligence, there is machine learning. And a part of machine learning, which is a deep neural network and convoluted, you will hear a lot of terms. A part of machine learning is deep learning, because each of these have a lot of ways, a lot of approaches. So a part of machine learning is deep learning. So these are the different aspects, and the reason it has come probably because computers can handle a lot of data nowadays, and the processors have become very fast, and that's why it has come into fore that the technology has grown to that extent and can handle billions of data within seconds. So I think that is where we start our discussion. So the next is Dr. Banani. What is this chat GPT chatbot? We keep on hearing about it, and that is kind of looks like a practical application of artificial intelligence. If you can just highlight on those aspects, Dr. Banani, please.
Yes, sir. Thank you, and good evening to everybody. I think without knowing these terms, we have been using these as you have rightly mentioned, sir. Every time we interact with, go on a chat with some of those customer support in any of the platforms, like say you're trying to get into buy some product, and you ask the like, for example, if you go into IRCTC, there's something known as Disha. So whenever we interact with those are the chat bots, and they are also artificial intelligence powered, but they are the older versions. And now a company which has partnered with Microsoft and some other big companies has come up with this chat GPT, which is basically mimicking a human system, which means you ask something and they give back a response, which is very similar to what two people conversing would do. And this is basically come out because of the training that has taken place. The AI companies have basically trained them. So chat GPT stands for the pre-trained programs, basically, and they can mimic human conversations, as I said. And now this is getting more and more powerful. And March 2023, we had ChatGPT 4 launched, and every time they are progressing. The good thing about these platforms is that if you give them a feedback, they learn from that feedback, or the number of interactions that goes on, they learn from those interactions and they modify the response. So just like you and I would do it, like, if you interact with somebody and you get a particular kind of response, then you keep on teaching yourself that this is how I should respond. Then this is what the chat GPT is also doing. So it has multiple applications because people are using it to write things. Say, for example, if you've had an interaction with a patient and you want to put it down in notes, the chat GPT, if it is fed in with this data of the notes of the interaction, it can make a quick summary and give it to you. Similarly, as has been mentioned in research papers, you could do it. So this is how it is moved. And there are other programs by other companies, and the same Open AI company has also launched something known as DALI. So there are multiple platforms. We will just have to get used to the different names, and they can do a Google search like you and I do. They can do a PubMed search like you and I do, and give you all that in a matter of seconds. We could take hours to sort it out, whereas this is because of the excessive capacity of the computers, as we mentioned, the fast processing, that you can get it within seconds. So that is what ChatGPT and chatbot is all about.
Thank you, Banani. In fact, when you open an app store nowadays, there is so much plethora of this chat GPT-like versions. So I think it is very tempting to kind of fall as a prey into one of these, and it becomes very difficult. In fact, the chat GPT, one of the problems with that is it will tell you that they are current till 2019. They don't have anything after that, or 2021. And the references, that one of the problems with chat GPT is whenever you want some kind of a reference, the references are all wrong. They will give author to one reference, and the title would be some different, and the chapters would be somewhere different. And what I have found, Google and the Microsoft, the Microsoft have a open AI platform called Bing, and that has very recent till 23, and the references are very good. They have PubMed references which are pretty correct. So I think one needs a research, and probably one needs to read on the different platform of this open AIs, which are getting more and more available now, and try to filter and see which one is more applicable to the things that they are being used for by the user. So I think it is a separate field altogether. And I think ISCCM journal should have at least one section is how the readers are going to find the best platform to do their work. So that's
right now, NEJM has launched a series on artificial intelligence.
A series of articles. So NEJM AI, which is free, one can download it.
Yes.
So coming to Venkat. So Venkat, now coming to our clinical issues with OpenAI, how can we utilize this artificial intelligence for early diagnosis of sepsis and the early deterioration of critically ill patient? If you can highlight on this.
So the biggest strength of AI, which we are talking about right now, is this has a strength that it can actually process a lot of information and data. If we come to the medicine, the highest amount of data which is available in a particular time in a dynamic way is an intensive care unit. I think other than imaging world and the lab, the other important area where AI can have a big role to play is ICU. And in the ICU, if you come across the point which you raised about sepsis and septic patient, we always have this problem of early recognition, early risk stratification of a septic patient in diagnosing. The reason for that is very non-specific early signs and symptoms. And we do not have a single diagnostic tool which is 100% sensitive and specific. Like now what we see a myocardial infarction, if you do a troponin in a subsequent or subsequent hours or in a trend way, you will have a diagnostic tool, but we do not have such tools in septic patient. But in the same way, in the later part of sepsis, we always see The diagnosis is easy, but the management gets complex. So picking up these patients in the early by a AI method, what it actually do is it actually analyzes both the structured data and non-structured data. The structured data is what you actually get from your vital trends from your monitor. It also takes the data from your lab and imaging modalities and your biochemical parameters, and the non-structured data that is from the clinician's notes and progress sheets. And this all been processed through a algorithmic model, and then they give a prediction. And these predictions were compared with the common utilized ones like QSOFA or MEO system or a SOFA or any other predictive models which we use in clinical scoring system. And they found to be useful in many systems. So sepsis, as we all understand, if we can early recognize and pick up, can have a different ball game together to manage them, because the management will be much easier. We know if a patient is in early part, the outcomes are different than in a later part. So that's why I think sepsis is one of the area where there's a lot of research going on in predicting or risk stratifying algorithmically in this way, where there's a lot of learning happening. So that is one. And the other areas, as we understand, the lot of data is created in the intensive care unit. If you see the vitals wise, mechanical ventilation wise, and a patient ventilator asynchrony wise, and this all can be processed and that can be utilized in a critically ill patient, and that can be alerted to the clinicians. The common utilization of ICU AI is right now prediction models, that is the prognosticating models and mortality prediction models, and probably those who actually can say you that these are the patients who are worsening. So I think we are working on that area, sir, right now.
But right, just like this early warning scores that we had, the news and the muse, which collects the routinely available data on the ward. And so they have come out with AI platforms where if you feed in this data, they outperform the common early warning scores. The AUC curve of the AI platform is higher than use in news. So I think that is where, and if they are available and if they are put on the computer, and nowadays one can feed data directly into those. So if you have pulse, blood pressure, so the trending, capturing the trend and the early deterioration, because in the other scoring system, there is one static number, and when the patient hits that number, then the score is done. Whereas the AI system will pick up the trend, and that is where it has the strength on this. Now, coming to Harjeet, Dr. Harjeet, how is AI going to help us in respiratory failure as a whole, and in ventilatory management? Any ideas, if you can throw in some thoughts on this?
Sir, most of the applications which we have as of right now are in their infancy, and they are not ready for prime time. So there are reports which are basically retrospective studies, internally validated, but no randomized studies which are multi-center or externally validated. So it's very, very little data and almost in the early stages, so that at this point of time, utilizing it on a larger scale is not going to be easy. However, whatever inroads have been made into management where we can use them, the first and the foremost is that with any kind of profession, you don't see standardization of skills across the board. So there are doctors and hospitals with different levels of expertise and skills. So with the advent of AI, the first and the most important thing, whether it is ventilatory or any care, you can at least standardize those skills to a basic minimum. So the level of mistakes being made early on can be decreased. So that is the bare minimum which these AI tools will help us achieve. If we move forward in respiratory failure management or ventilatory management, it starts right from the outside. Say, for example, in COVID times, there was a lot of debate as to what would be the ideal time to intubate a patient, what should be the time to switch from an NIV to invasive mechanical ventilation. And a lot of people did some work with AI as to the timing of intubation. Secondly, if we move a little more forward, early recognition of ARDS. Now, ARDS is a syndrome which is barely recognized by most of us in its early stage. And the most important aspect of ARDS management is to prevent secondary iatrogenic lung injury by improving ventilatory strategies. And if you can recognize this disease early, it can prevent a lot of complications. Thirdly, staying on the subject of ARDS, as all of us are aware that ARDS has several phenotypes. Now, if you broadly apply strategies to all patients of ARDS, they might not turn out to be successful. And AI might help us in phenotyping these different ARDS. For example, recruitment maneuvers done broadly in all patients might not be helpful. But in a phenotype where the lung is recruitable with poor compliance, that strategy might help. So it helps us phenotype and identify the right patient. So maybe personalization of care in the future. Recognizing ventilator-induced lung injury, there are alarms on the ventilator. There are things which we usually should be doing and seeing, but we don't end up looking at them and recognizing them. So if these alarms can start ringing, they will at least help us recognize ventilator-induced lung injury. Simple things, patient ventilator asynchrony. Many times the AIs can help us with what would be the best mode to ventilate a patient. Improving synchrony by standardizing sedation protocols. We tend to over-sedate our patients. We don't tend to give sedation holidays. So if there is an AI in the background to help us with that, that decreases not only the complications of iatrogenic issues, but also improves weaning. Coming to weaning, it also can help us with timing of extubation, identifying patients which might be at high risk of extubation, identifying patients which might need prolonged ventilation and early tracheostomy. And those patients who would tend to deteriorate, as Dr. Venkat just said, prediction models are there, which can help us identify patients who might improve with early ECMOs. Most of our patients end up with salvage ECMOs. So the results are not great. But if we could identify a subset of patients who would respond to early ECMOs. Lastly, interpretation of ventilatory graphics. That is an interesting tool because all our ventilators have graphics, but very few of us end up interpreting it. So an AI-based tool not only tells us what those graphics means, but also gives us solutions to improve the ventilatory care. So all in all, first and foremost, standardization in expertise. Secondly, where gray zones exist, maybe giving us some support to make better decisions, personalization of therapy by identifying phenotypes, and obviously early warning systems to prevent iatrogenic lung injury. So a lot of AI-based tools coming up, and some of them we'll see in the recent future.
Thank you. Thank you, Arjit. In fact, one of the audience have written there is a new reinforcement learning algorithm called VentAI that has been validated for automatic ventilator settings. So, just like I think like in CPR and the defibrillation, now there is an AI already incorporated telling us what is the frequency right, is the depth right. So similarly, it has not come into the ventilator so much as yet, but I think in no time, the AIs will pick up the ventilatory part as well, and we'll be seeing more and more use of it. Now coming to the hemodynamic monitoring, where there has been a lot of development and also practical application. So Dr. Garg, what are the application of hemodynamics monitoring and management of and the use of AI in IC?
I think AI would be one of the important tools in the hemodynamic monitoring, but we need to understand both the aspects when we say we can use the AI into a hemodynamic monitoring critically ill patients. So when we talk about the critically ill patients, hemodynamics is just not the cardiovascular system. We know that in a critically ill patient, hemodynamics is based on the multi-organ involvement, or you can say a multi-dimensional input has to be created. So clinically, if you see that various monitoring tools that we have, sometimes some of them are dynamic and some of them are static one, and the integration is a big issue. This is one. Second important aspect when we have some scope of AI is, as you mentioned earlier, the predictive models. We know that if the urine output is going down, if the lungs are getting more soggy, if there is some change in the mean arterial pressure or the lactate levels are increasing, we can understand that then something has already happened. So we need to have some predictive models which AI can give. And that will give us a very good idea that this strategy needs to be done for this particular patient. Now, actually, in AI, we need to understand this is a concept which AI has picked up from the engineering aspect, where they call it FAST, functional analysis system technique. I think that same system has to be there for hemodynamic monitoring in critical care system. It basically works on three questions: when, why, and how. In critical ill, we know when means it has to be a real-time continuous monitoring. Why? We know that the hemodynamics has to be predicted, and before the insult happens to the organ or the cell or the mitochondria, we have to do something. But the process here is how. If we see the data which is coming from hemodynamic monitoring in the literature, almost every year you'll find that there will be almost 10% to 15% of data will change, which will emphasize that some monitoring tools needs to be done. Now, this has to be incorporated into AI system. Then it will develop a best model, and this data, which is upcoming, because our management is changing, like you were talking about the mechanical ventilatory strategies, they are changing. We are understanding various phenotype of the ARDS pictures. So those will have impact on ARDS. So this data has to be imputed into the system of AI. They need to understand, develop an algorithm by artificial intelligence, and give us a variable that we can give some meaningful outcome. This has yet to come. We are having certain models where they predict that this patient is going to have hypotension in subsequent times by having input of data from various sources. But how reliable those data are? We know that CVP was one of the good fluid markers decades back, but it has failed. We have now moved to focus using ultrasound for fluid management, CE for fluid management. Again, they have their limitations. So I'm sure in coming times, these recent interpretation of various data will be inputted into the algorithm of artificial intelligence. We need to have some criteria. So we need to understand that independently, artificial intelligence probably may not be giving us a real-time absolute outcome hemodynamic parameters that this needs to be done. The human involvement has to be done in some way to guide the artificial intelligence. This is what I look for the future, wherein we need to have some criteria that this input is okay, and that we can again take help of AI. Then they can integrate all those data, and then they will give certain strategies for us to look for. So probably in coming times, we will have some monitoring tools where we can integrate the data from various resources. Not only data, but the updation of the data also needs to be updated, because the tools that we are using are of variable manufacturers, and they are of variable disease resources. For example, a patient who comes with hepatic disease is not equivalent for hemodynamic monitoring as a patient who comes with renal failure, as a patient who comes with respiratory failure. So the data from all the three with regards to hemodynamic monitoring is not same. They may give the same value, but the interpretation would be different. So probably here, AI will take input from all those data and would say to us that if this patient was a primary liver failure patient and this hemodynamic monitoring is coming this value, probably this is our interpretation. So what I say, we were talking about a decade back about the personalized monitoring. So probably the artificial intelligence will make it futuristic to look for those AI-based individual personalized hemo monitoring for some guidelines to us.
You're quite right. I think it has to be a human intelligent use of artificial intelligence will become very important in future. But as you mentioned, predicting hypotension is there now present in a lot of these newer monitor versions. Now the question comes, I have a monitor which will tell me that, look, this patient will drop the MAP below 65 in 15 minutes. So what should I do? I can't, because his MAP is okay now. I'm not going to start him on vasopressor. So should I keep the vasopressor ready in case if he, because the chances are very high, but that will be a foolish, because I know he's going to develop hypotension. So what am I going to do now so that he doesn't develop hypotension? Is that how do we trigger that?
Yeah, I think this is, sir, you have just raised a very, very important question. So I'll put it this way. that it is triggering us that this patient is going into a hypotension after 15 minutes, so this is predicting it.
Yeah.
But I think rather than treating the hypotension, this window period should
Yeah.
make us wiser that why this patient is going into a hypotension for us. Whether this patient is non-responsive to antibiotics, whether this patient is a cardiac coronary which is compromised, whether this patient is going uremic failure, whether this electrolyte imbalance. So I think that window period should give us a time which is useful tool for us that why this patient will be going into hypotension after some time. So I think this will be the utility rather than, as you rightly said, sir, rather than starting them on vasopressin or adrenaline or something, or just upgrading the antibiotics, we can say send a sample for backpack, we can look for the blood cultures, we can look for the respiratory parameters, and
that is what is futuristic, because at the present moment the monitor just tells us is going to get hypotensive, but doesn't help us in any other way. So I think that is where the things are going to evolve now. I think it is important to know if a person is going to get hypotensive, which we could not predict by clinical means. But I think now is the time that now we use our brain over the artificial intelligence to find out what could be the reason for that. So I think that's how we need to imbibe the artificial intelligence, just how we imbibed the computers many decades back, you see. So now we need to get the artificial intelligence and then use our brains to help us. So coming to Banani, this is a very important question. How do we use artificial intelligence in solving clinical problems in daily clinical rounds? Because we want to discuss some practical ways, because it is there now. All the smartphones have OpenAI platforms. So how can we use it in the clinical rounds?
Yeah, sir, it's, I think, still a little early. But nevertheless, there are certain things like, for example, we are not in the habit of checking allergies or those kind of things. So we should make it a habit, and these tools can tell us by going through the earlier medical records whether this patient has got some allergies or whether he's got some reactions to some drugs. So that is one kind of information that you can get. Then we have also heard about how we can fine tune the ventilation, the hemodynamics, and the diagnostics at the bedside by using the AI. So this is the second aspect. The third aspect will be that you can go for predictions. As Dr. Rakesh said, that you can probably predict the course that the patient will take by looking at his past records, his current admission data. But for all that, as has been rightly pointed out, there is a lot of data that has to be fed into the tool so that there is an integration. And that feeding part or that interface part is what is very important. And as Dr. Venkat said, that there is some structured data and there is some unstructured data, and all that needs to be properly fed into the tool. Apart from that, what it will help us enormously in continuous monitoring. You can also do resource allocation depending on, can tell you that, okay, this patient is this much sick, so you need this much resources. So based on your categorization of, you can decide all that. And finally, you can have a personalized treatment plan based on the omics data perhaps that it can draw in, like what is the genomics of that person and what is the pharmacological makeup of this person and how is he going to respond to your medicine. So these are certain things apart from the aspects that has already been highlighted that you can use at the bedside, and it will be probably it will take another 2 to 3 years to become more we come to that stage when we can use all these activities on a daily round basis. As of now, you would probably not be using it that
much. Recently we have been very interested in use of AI. So during rounds, a lot of questions come. I'll give you an example. Somebody is putting a Foley's catheters and a resident asks, should we give prophylactic antibiotics prior to putting a Foley's catheter? Now, the options that we have to look for it is either you go to UpToDate, or you do Google search, or you go PubMed. And we have found it very difficult, when you put this into these platforms, it's very difficult to find the right answer. You have to go through a lot of literature. But if you put it in an OpenAI platform, they give you within seconds a reasonable approach to this problem, and some of the OpenAI also gives you good references. So I think if we start using it for the questions which come up during the daily ward rounds, and just put it in the OpenAI platform, they ask me anything, you just type it down and see the responses, and that's how probably we might build up and start using it intelligently. Not all of them are correct, but at least they give us an idea, a guide towards which way we are heading. Dr. Pradeep is saying there are questions coming, so let me see.
While you're looking at the questions, I just say that the more we use it and the responses we give to it, the tools are going to learn it, and the responses are going to be modified. So it's a good idea, sir. As
so I think it is worthwhile using, because we have started using it in quite a few problems. We had a methotrexate overdose. So instead of going into the different PubMeds and update, we just typed it in OpenAI platform and get a good summary within 5 seconds. So now coming to medical prescription. When we write drugs and others, Venkat, if you can just describe how will AI help us in writing medical prescriptions in ICU?
Sir, I think to be honest, that we have not have any hands-on experience of this medical prescriptions by AI. But in day-to-day rounds, what happens when we go to the our cases? What happens over the night of 24 hours? We get a lot of information which has been there, like you see from the monitors, has already been pointed out, from the ventilatory graphics, from labs, and then from the imaging. What happens is every intensivist takes a good time or needed a good time to actually go through all of them and synthesize into a final action points to that. And then we finally come to a chart outing that what treatment plans need to be done. I think AI will help in actually taking out this burden of actually over the 24 hours, all the information which is there can be synthesized, as we are seeing the direct one-to-one nursing ratio or the clinician ratio is slowly not been feasible in many contexts. So if the AI availability is there and it actually monitors, titrates, synthesizes into an actionable points, and then we come to a goals and the final actionable treatment, in this medical prescription, AI can also play a role in avoiding many medical errors. Like we actually have some integration of some of these apps like SIMS and other, which actually prescriptions has been screened through them. And they actually pick up drug-drug interaction, drug errors. The particular drug is not been indicated in the particular patient. So this is all a screening of the drug seat, where this particular patient needs or not. And this can be actually get the alert to the clinician there in that point. And that can be a mode in the future, like where we can actually, is this drug particularly needed or not, and this duration is over, and the drug-drug interaction. So this can be the initial stage where we can see, and then the decision-making system, the DSS, which is coming in a big way in either when we see in UpToDate model or any other model, where the clinical decision making system is also been integrated in now into the AI, and that will come in a big way in the future, where you take a clinical decision of diagnosis or investigating a patient, and that will also be a part of this.
There was a question on, can clinical examination be held by AI at the bedside to any of the panelists? What I can say that, facial recognition, people have done work on using facial recognition for predicting early warning of a deteriorating patient. So that is one of the ways AI has been used in this. So
Sir,
any other comments?
there are investigators who actually looked by both the sound and light sensors and facial expressions in an intensive care area, where ICU delirium has been picked out, the sleep pattern, ICU delirium, noise, and these are all by examination of the camera sensors and sound sensors available near the patient, not just the monitoring. The appearance of the patient, the behavioral changes of the patient, the facial expressions of the patient, all this been captured by the sensors. These are sound and light sensors, and this been implicated. And CAM ICU score has been compared to pick up the delirium in them. So yes, these are only a visual appearances, not a tactile, which is again a gray area, and which is again actually a limitation of AI, which we
Right.
say patient doctor interaction, patient doctor, the touch sensation and examination feel, a tactile feel which is not there, but the visual appearances can be a possible phenomenon where camera captures.
You know, we have a audience here, Dr. Avnish Khare. He's from India, but maybe based in US now. He's a board certified, American board certified of AI in medicine. So, you know, they have a different stream now of certification of AI in medicine. So that was very interesting to know. So now coming to, there are so many other questions, limitations and drawbacks. Let me come.
Sir, sorry to interrupt. He has asked a question about ethical application of
Yeah,
emerging technologies.
ethical and legal applications. Venkat, it was asked to you. Any?
Yeah. So, sir, coming to the ethical and legal application, there are very interesting findings which I find with AI. The first interesting finding is, do you take consent when you use AI? So you give a consent when some doctor treats you, that, okay, you go and give consent. Then when it comes to AI, where is the consent? And the patient is now under a ventilator, sedated in a critically ill, is the consent required? That is one. Second, what is the security and confidentiality of this data when this data actually been said with an AI which actually processes through the algorithms into a third ear? So what is the security and confidentialities and that? And there is another interesting question. Suppose you say this has been taken care by AI based decision making system. Suppose the things go wrong, who is legally liable? Is the clinician who is using AI or the AI himself? So these are the dilemmas which are there. And coming to the ethical issues like ethnicity, social issues, see, we all see the hemoglobin levels, vitamin D levels can vary from one part to other, one gender to other, one ethnicity group to the other ethnicity group, the happen, the behavioral changes, and these are all not a part of the AI in many areas. Another interesting area is end of life care. See, we take the context of the patient's different comorbidities, age groups, and the family, social, and every aspect. And then we will say this is probably the patient who is suitable for a end of life care or a comfort care. These are the areas where I think the AI will lose its chances. And biggest limitation, as I was pointing out, the biggest limitation is the patient and the doctor's interaction. And the family wants them to see they being given a touch and the affection, love, that the bonding which they carry with the faith and trust, that will be a big gap in many situations.
Yeah, those are the issues which needs to be addressed as the things evolve. Now, coming to the family communication and the family conflict, Dr. Rakesh, what is the role of AI? Because now families, they are also have access to a lot of these platforms. So how to handle this issue?
Sir, I think we do not have a lot of resources which has come up that how AI will be good for communication aspect. But if you see the trends which are going on, when we talk about communication for a critically ill patient, there are two aspects. One, we need to analyze the patient present information into a capsule format for a layman how to emphasize it. So as we have already discussed that once we start using the AI, it will give a summary of the concerns of the patient. This is one aspect. So when we get a summary, it becomes easy, because when we communicate, we cannot say that kidney is not functioning, liver is not functioning, the heart is not well, it's 50% working. So these type of information may not be the correct communication to the patient family members. We need to communicate the patient as a whole, that how he is behaving and what will be the survival rate or what will be the improvement rate. So probably AI will integrate those various information into an integrated model and will give us the critical care physician approximate direction that how the patient is going to behave. And we are talking about the predictive models. So we can definitely look for, rather than the statistical model of ROC curves and survival curves, it will give us an idea that the chances are this much, will be giving us an idea. This is one important aspect. Second, which I perceive that will be good for communication, is when we see the patient attendants, their behavior also influence the communication skills. So probably in the coming time, if we have the input of data of the patient and the family members, probably it will say that this is the way you should provide personalized communication to the family members. So again, we are coming to the important aspect of individualized communication or personalized. We cannot say that if somebody is having a AKI, he will have a survival rate of say 50%. We have to individualize based on the multi-organ involvement in this aspect. So probably AI will guide us that these are the concerns of the patient, these are the possible strategies or mitigation strategies that this patient would survive in this aspect. And probably sometimes when we talk about those medical ethics principle, and Dr. Kola was also mentioning about the end of life, which is becoming an important issue in ICU setup also. This communication prediction will also be provided by AI, probably it appears. And then we can always try to counsel the patient family members that this patient probably would require end of life care, and we can counsel them so that the acceptability becomes much better in those groups. So probably I think these are the various concerns that we look for. But as Kola, I think I can just, Dr. Kola was mentioning, as per present, when we talk about the August of 2023, various literary sources has confirmed that whole responsibility of whatever AI says is on the treating physician. So we have to take the responsibility of whatever interpreting it. I think at this point of time, we cannot give the AI to become a master. Master will remain the critical care physician. Probably AI will be a slave to master. That is, it will be guiding the critical care physician. Their integration, their understanding will also be involved before it is finally communicated to the patient. Sir.
Yeah, as you mentioned, I distinctly remember I had a patient's family member. They are from a very low educational background, and they just wanted me at the end of all the conversation. They just asked me to tell whether the patient is plus or minus. That's it. Said, sir, ye plus hai ya minus hai? I asked to thoda minus hai. That's what they wanted to know. So that's why this is precision, personalized. That is what they want to take home, aaj minus hai. So, that is where I think, as nowadays AI not only take texts, AI will start taking audio, AI will start taking images, many other things. So if an audio conversation is put into AI, they will interpret it and they can convert it into text. They might tell us what is the best way to answer those kind of questions, and has to be customized and all. Now, coming to Dr. Garg again, there has been a lot of questions as regard the publication and as you are well aware, the plagiarism part and all. Dr. J. Prakash have asked that this Turnitin, which can check plagiarism through. So how are you handling? You are the editor of IJA. So how are you handling this part?
I think this will be an important question. A lot of turmoil is happening in the among the editors of various journals across the world. So there are two aspects. It has some benefits to us. So I was just looking through various papers, and I was myself, just for my learning purpose, I will see how the AI-based platform is giving an analysis of a publication. And I found that it is working to a large extent. So probably it will help the publishers or the editors of various journals to analyze the publication, which published paper which has been submitted, to look for whether there is any gross issues or not. But on the other hand, when I was looking for those papers, it is very clear as of now. Let's say, for example, I will say that the difference in the survival rate or difference on the patient on mechanical ventilation in an ICU patient is say 3 days versus 3.1 days with p-value of 0.001. So the AI will say that it is significant. So 3 versus 3.1 is clinically not significant for us, but the AI will not input this data unless there is a lot of data which will say that for mechanical ventilation, a difference of 2 hours does not mean anything. So this clinical interpretation is not being put into the data metrics of the artificial intelligence. I hope this will come up, but right now it say the analysis part, the checking part is okay from the AI, but its interpretation still has to be based on humans because we take so many aspects of interpreting a value, which again will require human consent, and there are limitations to it. A person who is working in a low resource setting versus a very high center which have all multimodalities management, the decision will be different with regards to a particular value or a particular measurement. This AI data which is rightly available is not able to differentiate those aspects. That is what, for the publication purpose, we need to be very cautious. And for the purpose of publication, it has been very clearly mentioned that the artificial intelligence cannot be an author to a paper because finally we are working on human beings. So the editors-in-chief of more the journals, in fact, even I received one paper in which they have mentioned one of the author has to be ChatGPT.
Yes.
So I have to request them that he cannot be an author. He can mention in acknowledgement because the responsibility of a published paper for whatever reasons, we cannot blame ChatGPT for it. So he cannot be an author for publication. So there are pluses and minus both.
Right.
It will help you for the alt metrics also.
Now, what is that, Banani?
The alt metrics can also be improved by AI, like
Yeah,
seeing
the
Yes.
grammar, the English part, those are things are allowed, right, Dr. Garg? One can use AI to improve on the grammar, on the English interpretation and the other text that has been written. So I think that is one of the best ways of using AI at the present moment, is to just put it and see whether there is any grammatical mistake, whether the context is correct and things like that. Now coming to humanization, there has questions are coming, is AI going to dehumanize? We did touch on these aspects. In fact, there is a saying that if AI takes a lot of load off the clinician, then clinician can devote more time to the patient. So any comment on this, Dr. Banani?
Yes, sir. Well, as you have all already said, that there are certain points at which a human face is required. The patient's relatives will always be looking for somebody to come and talk to them. The empathy, the simple language in which you can put it without bringing in a lot of figures and a lot of percentages is not possible with an AI. Even if you have a robot who cries and who can show facial features and all those kind of things, it will still be different from somebody like, a doctor sitting in front of them. And that is going to make a huge difference, I think. The second aspect is the nursing care. Some parts of the nursing care can be taken over, like the charting of the vitals and the intake output and maybe the drug infusions. Those can be taken over, but the actual preparation of the drug and the administration, checking the interactions of the various drugs when they are administering, all those things can be helped by the AI, but cannot be done all obviously by the AI. And then I would say very mundane tasks, the back care, the cleaning, the mouth cleaning, the eye care. Where do we ever see that these will be taken over by AI? So there is going to be some dehumanization. The data entry operator who sits and, keeps a record, or the billing person, or maybe the person who's making a note of all the patients who are coming and going and the relatives who are coming and going, those kind of things can be taken over by AI, but certainly not these tasks which we think are very important and require human interaction. And counseling can be helped by AI, but certainly not taken over by AI.
Dr. Pradeep, you have any questions for the panelists? Any thoughts?
I think the discussion is going on in at its, I think, top pace. It's going on. The kind of discussion which we are doing, I think all the participants must be enjoying it a lot. But I see that there are lots of questions on the QA box. So if we take those questions,
One was on antibiotic stewardship. Will
yes,
AI help in antibiotic stewardship? Any comments from any of the panelists?
I think
yeah,
Dr. Kol.
Venkat, bolo.
Yeah. So, sir, what I feel is what right now we are doing is your antibiotic stewardship committee keeps on actually looking at your antibiogram every day, every maybe once in a year or twice in a year, and integrate that into the system, and then they make it available to the clinicians, and then every patient go on, keep on checking. If suppose AI comes into play and the microbiological lab is integrated to that, it will happen dynamically. Every day, every culture positivity, every patient who comes in, that data will be integrated, and automatically, if you know what is your antibiogram and you know what will be your protocolized antibiotic required for your hospitalized patient and for your community acquired patient, and that again, each patient, whenever they grow something or there is a suspicious of some infection, that will be an alert and trigger there, that these are the possible antimicrobials which will be useful in your patient. And that kind of integration will help in probably doing a stewardship in a more appropriate way and a dynamic way in a real-time scenarios.
Quite right. I think it will help us in making smarter antibiogram. Sometimes when we look at the static antibiogram, they say these are the 3 most common cause of VAP. So, Pseudomonas acinetone and Klebsiella. So does all patients with VAP need to be empirically treated with all this till we get a culture? That becomes a big difficult issue. What these antibiograms do not tell us, the commonest cause of VAP in the first 6 days of ICU stay in my ICU is Klebsiella, is not acinetone. So, and that's why I do not need to cover probably in the first 6 days of VAP. That is where might be that AI will keep a track who is getting infection when, with what organism, and what is the resistance pattern, the antibiotic history and all. So I think that is a very big area where AI might play a big role in future. And I think that will really be useful for us, especially with this MDR bacteria.
And integrating the microbiological data with the clinical information and laboratory and
That's
dynamic
right.
vitals information will give us a more productive way of actually selecting an antibiotic, sir.
No doubt, no doubt.
Sir, can I request, somebody has asked, what is the AI platform you suggest to be used at the bedside? Like you said at the bedside, you sometimes type in questions and ask. So maybe that is a good thing to ask.
At the present moment, I am using OpenAI ChatGPT. The only problem with that is the reference. If you say that, well, they have given you something, in the question, if you ask, please give me references, don't trust on those references. You can ask the same question in the Microsoft. They have Bing. I have seen the answers are better in this. Somebody has written www.glass.health. It is far better. Well, we learn. So, I think this is AI. This is what we are learning now. So we are going to, glass.health. So please note this. One of the audiences have written it. I have not used it. So I have found OpenAI because it is free. The earlier versions are free. Most of the newer versions are going to going to ask you for a price. So earlier you just use ChatGPT to start with. I think it is an easier platform.
There is the associated question which says that, is there any dedicated AI designed for medical or critical care application?
No, not yet. Not yet.
We don't see that there is any such kind of application is there in the market. And what are the authentic AI models for critical care medicine? I think it is a futuristic thing. It is yet to be decided, isn't it? If
Yes.
anybody wants to say something, they can comment. Then can all clinical pathways be incorporated as AI so that mistakes are minimal? AI looks promising in that case. I think already we have discussed because it is almost a neural networking system. Finally, how much networking we can incorporate, that will ultimately answer the final question, isn't it, sir?
Yeah, you know, Pradeep,
Yes, sir.
one of the biggest contribution of AI in critical care could be this natural language processing skills, the NLM skills, will that picks up the words. You know, normally we write clinical notes, and clinical notes are unstructured texts.
Yes.
People are now typing it in computer, but they are still unstructured texts. Now, what AI does, it picks up the words in those texts. And say, for example, a patient who develops sepsis, the AI will pick up the words which were used by the doctors while they are doing the daily charts, the words which have been used most frequently, and the patient landed up having some complication. And as soon as, you know, that is reinforcement learning. Next time when a patient is having, if you type that word, it will tell you that the patient is most likely might have this problem in future. So those are this natural language processing like delirium. You know, how to detect deliriums, it was mentioned. Again, the way we write notes, that might also pick up whether we are suspecting delirium. We don't write delirium all the time. We write a lot of other words. So I think natural language processing will become very helpful. So I think it's an evolving field. We can keep on discussing. This is such a, we have crossed our time.
And
So,
somebody has recommended, sir, that they have got an annual review by Brain X AI. And that Brain X AI, that is there in the brainxai.org. And here they say that it is a year 2022 in review. And that gives an idea about artificial intelligence landscape in each specialty. I think that is somebody's suggestion. I don't know the name because it is showing through iPhone.
right.
Then
You know,
how do
I think
Yes.
that is that person from the US who's done a fellowship in AI.
You know, I will give you an example. Recently, we are doing one sepsis research, collecting lots of data. So I gave it to my statistical person. He said, "Sir, just give me 10 or 12 variables for multivariable analysis." I had 150 variables in that data for multivariable analysis, logistic regression to come out for independent predictors of mortality in sepsis. He said, "I can't handle that. You just give me 10 or 15 variables." And that is where I thought AI might be very helpful. AI doesn't require any particular numbers.
Yes.
So if I can give that data to an AI and with supervised learning, I know the patient lived or died, and I gave the 150 variables, the AI will pick up which variables might be independent predictor of mortality in that sepsis, which the standard statistical analytical methods are not able to do at the point. So I think that will be another very good way of utilizing AI in clinical research, especially if we have big data. And that is where I think our strength would lie in India because of the huge population and the data that we can gather. You know, 100 ICUs, we had a meeting recently, 100 ICUs. If they start putting data, we cannot utilize standard statistical methods. We have to use AI tools in order to get a meaningful analysis of those data. So that will be my take on that. So
This
Pradeep,
Dr. Avnish Khare, sir, he has suggested that
yeah,
Brain
Avnish is the
X
one
AI.
who's
Yes, sir.
board certified in AI.
Board certified AI expert, sir.
Right. You know, another use of AI is, as you know, there are 3 very big databases in the world, which are free databases with millions of patients. One is this Mimic4 database
Yes.
from University of Harvard
They're-
and Mass
They're
General.
open and free.
They are open and free. There is one University of Amsterdam, database, and there is Philip eICU database. These are millions of patient data, including their ECGs, their hemodynamics, ventilatory graphics, and they are open to do research. The only way we can do research in those data is by using the AI system in those, because the number of data is huge. It comes to thousands. So I think that is another way of looking at the different data. We can do research with data which is available on the net from the different healthcare systems of the world. So that is again the way where the world is progressing towards doing critical care research. Dr. Rakesh, so any final words from each of the panelists? Yes, starting from Banani, please.
Sir, we have not touched about the role of AI in education. Last time when we had our foundation day, we had Professor Yugan Mudaliar from Australia demonstrating to us how he was using virtual reality in training students for, you know, just something as simple as placing lines or something like that. So simulation will go a step ahead with virtual reality. You may do something without even having the mannequin in front of you. So that is one aspect that I'd definitely like to say, apart from various other things that we have discussed about research and learning and things like that. So
any points, final points on AI?
Sir, excellent discussion. And in fact, a lot of learning points. Only thing is that every good deed will not go unpunished. So you need to be a little worried about where we are heading. So there have to be some limitations to this AI. And one realistic thing which happened in our hospital recently is that our hospital was hacked and we lost all data, leading to lack of confidence. What is important to understand is that if you had patients, but if you have a bad machine, it can affect millions of patients.
Yep. Just imagine if Gmail gets.
I'm not sure. So if you have a bad doctor, you can possibly.
Your voice is not coming clear.
Doctor, there is a problem with internet.
Yeah.
Dr. Harjit, are you finished?
Am I audible now?
Yeah.
Audible now.
Yes. Okay. So the major problem with AI is that if a machine gets hacked, you lose confidentiality. Not only that, it can be used as a mode of bioterrorism. If the algorithm is jumbled with by someone, it can hurt so many millions of patients because you are completely dependent on the AI for such a lot of data, and you tend to rely on this data. So if it gets hacked or there is a virus which can be sort of integrated into this machine, it can really, really play havoc with a lot of patients.
Is our time out, Pradeep?
Sir, we can get the final wordings from Dr. Venkat as well as Dr. Rakesh.
Venkat?
Sir, I feel it is a learning curve for both the AI, because every time we interact with AI, the AI learns from all of us and activities. It is a continuous learning process for AI. Similarly, it is a learning curve for all of us. And as you rightly said, maybe a few decades back, we integrated a computer system into us. In the similar way, this is high time that we start integrating. Yes, it is not the right time right now to switch over, but start integrating, learning from that, and there will be a learning curve to reach to a perfect match where both AI and clinical acumen together put a productive output.
Yeah, the way I look at it, probably AI is telling us that, look, what you are doing now, robots can do it. So your intelligence is much more than robots. You better let the robots do their work. And now you start thinking above the robots, so that's what AI is telling us, that a lot of things that we are doing can be done automatically. So Rakesh, any last few words?
Sir, I will just say the AI appears to be having a promising future, sir. But I'm sure that it will not be replacing the human beings. Second important aspect is we need to look for something called data scrutiny or a data filtering. Because as we used to say in the past, sir, that Google is a garbage in and garbage out. If you search something from the Google, because there is no peer reviewing of the data which is available on Google. If the AI will pick all those unscrutinized data, then it will give the haywire results. So there has to be some system. I'm sure this will come up, that how to have a data from a reliable sources, and then it will give that this is the data output that they are giving it. So that data scrutiny probably will come in future, but I'm sure that this will be helping us. It should remain an assistant to us rather than to a master to us. I'm sure it will be helping in that sense.
That's right. Quite right. So we learned a lot of things during this panel discussion from the audiences as well. That was really good. So Pradeep, if you can ask the ISCCM office to save this question. So there are a lot of information there which we might help us on the websites and all those kind of things. So any final words, Pradeep?
Yes, sir. So I think it was a very, very useful discussion, because what we talked, I think we have to see in future all those things, although some of those things which we are practicing. But I think there is a long way to go and to understand the nitty-gritty of artificial intelligence. That was what we have kept as the header of this discussion. We discussed about ChatGPT, sepsis, CRDS, ventilation, hemodynamics, ethical aspects, communication, then even article writing, publication, dehumanization also. We talked a lot of things. But ultimately, what I understand at the end of the day is that complete dependency cannot be done. We just use artificial intelligence as our supportive measures or as a gap filler, where we feel that, yes, I feel that, yes, little bit of guidance I need at this point of place. There I feel that currently that is the point where actually we should use this artificial intelligence for clinical practice. So,
one of the audience have put it, in future, we may need AI stewardship. Very aptly.
Yes, yes, sir, it will be. So obviously where there is an algorithm, it will be a straightforward thing. It will be a mathematical approach. But as Dr. Harjeet Dumra said, if the software gets corrupted, and then one algorithm will get interlinked to other algorithm, and final outcome you can just imagine. So all those things we have to keep in mind. And I thank you, sir. Thank you for doing such a beautiful discussion. And I must thank all the panelists, Dr. Banani Poddar, Dr. Rakesh, Dr. Harjeet Dumra, Dr. Venkat Pola, for taking out their times and completing this job. I think definitely, because being a new thing and everyone, nobody is master on this topic, all of you must have done a very hard work.
Itna padhai kiya.
Yes, I can understand.
Was it taken from OpenAI?
No. NEJM and Java and things like that.
A lot of literature. To my surprise, the
Yes.
moment we go into any of those topics, there is a huge amount of literature available in every area.
Yes, yes.
Something.
So thank you all. Thank you very much, and good night.
Thank you.
Thank you, sir. Thank you, Tony, sir. Thank you all.
Thank you.
Thank you, sir.
Thank you. Thank you so much, sir.
Thank you, Ninad.
Thank you, sir.
ISCCM team. Thank you.